to come here and give us this talk. Dr. Lilia, she's from the Department of Internal Medicine from the Hospital José Eleuterio González from Monterrey in Mexico, and also from the Department of Internal Medicine, Hospital Christus Murgueza Alta Especialidad, also in Monterrey, Mexico. So Lilia, thanks again, and the floor is yours.
Thank you. Thank you, Tiago, for the invitation. It's also for me not so used to make the presentation in English. We are used more than before, but I'm sorry for the mistakes spellings. So I met Tiago after we went with Professor Ronco, and maybe you can see some similarities between what we saw and what we did because of the formation. So I'm an internal medicine and a critical care nephrology, and also that makes me to find a different way to look the kidney. But as we are looking for the complete picture about Mexico nephrology, I will start with the formation of the nephrologists, and then we arrive until the things I really do here and I love to do. So here is Monterrey. This is my city. I really like to present you Cerro de la Silla is the emblematic picture of the city, and I know that you have something like that, and it's very nice, and I really would like to go there and meet you in person someday. So thank you for the invitation. This is my declaration of interest. Here is Monterrey in Mexico. It's in the north. And these are the two hospitals that Tiago already mentioned it. So I don't have any conflict of interest for this lecture. So the first thing is we can talk about is the education and training nephrologists. We have the Consejo Mexicano de Nefrología. I think maybe in Brazil is something like that can say that you have a really good education, and it's we are all the same, and we can see this patient because we go through exam, and you have to pass the exam. If you don't, you can't pass the Consejo. So we have to do it. So in Mexico, there are around 1,196 nephrologists, and we are around 9.1 nephrologists per million per people. So it's a lot of work, as you can see, but you will see around this presentation that we are not very well distributed, and I think maybe you have the same problem. So most of the nephrologists are concentrated in 5 states, not in other areas, and so this is a very good opportunity for the new nephrologists maybe to go there. So we have in this country 24 schools that can formate and educate nephrologists. These training sedes are between the institutional health is IMSS, ISSSTE, and Secretaría de Salud. This is the 3 about the government. And then you have SEDENA and PEMEX, that it's also government, but this is about the also a kind of private. And then we have some others as private, but it's very short. And you have as famous, I think you have here, and maybe you have some nephrologists come here in el Instituto Nacional de Nutrición y en el Instituto Nacional de Cardiología. These are the most maybe famous around the institutes in Mexico City. And then we have the centers from IMSS that these are also important, La Raza y el Siglo XXI. I am in another center, as I see, and I show you here, and this one is the one that we have nephrologists in training. This is Hospital José Eleuterio González, where we have at this moment 15 nephrologists in training. So we are also a hospital with nutrition. The only 2 sedes we are asking for complete nephrologists, the complete internal medicine specialty. So because of that, all our trainings are internal medicine and then nephrologists. And this is the distribution about the adult nephrology and pediatric nephrology. See, we have this a very huge blackout here in about the pediatric nephrology. We have here in Monterrey, we have 2, but this is kind of new, no? So we are very need to do something to get a better situation for the other parts of the country. As you can see, the south of the country is very lonely about the nephrologists. So everybody who is from the south should go to the center of the country. Most of the people go to Mexico City, and some of them have no possibility to have any treatment with a nephrologist. So also the age group is going higher in our, I think, our time. I'm here between of these 2. And maybe most of the nephrologists at this time are in this average. And also the other interesting thing is how many nephrologists we are for patients. And here is what we say, that most of the nephrologists are concentrated in the 3 places. It's Nuevo León, Monterrey is the capital of Nuevo León. Then you have Jalisco, famous Guadalajara, and then you have Mexico City. So the nephrologists, most of the nephrologists of the country we are here. And then you have the other states quite alone. So we have also that concentration problems. So about chronic kidney disease, we have in Mexico, this is like a 5th cause of death. And we have like 2,000 deaths per year. Around the 2018, we have 800 Mexicans who are needed of kidney replacement therapy between hemodialysis and peritoneal dialysis. And we around in 2018, we had 573 kidney transplants. But we know everybody about the pandemic. This is go very low after these 2 years of pandemic, but now it's getting better. So we have in the last 20 years a very huge growth about the chronic kidney disease. It's like 274%. So most of the patients don't have any symptoms, and when they arrive, they were like 4 or 5 stage. So most of them don't receive any treatment. And for us, as much countries, this is a emergency in the health, in the public health. So we have to focus around this maybe more often. So in Mexico, as in most of Latin America, the highest prevalence of incidence of chronic kidney disease is diabetes, hypertension, and obesity. And in Mexico, the most common cause is diabetes, and 50%, 51% around, and maybe 30% is unknown, and they don't have any biopsy. And only for the diagnosis in Mexico, for cause of the first diagnosis, not hypertension or diabetes, is like 10% of chronic kidney disease. And most of these people who have the diagnosis lack their treatment. Around 50% don't have any treatment, and not even the consultation with a nephrologist. So, and also it's only the 3% of the population in Mexico have a private health insurance. Here in Mexico, we have the private medicine and we have the institution medicine. And the private medicine with insurance, it could be easier for the patients, but it's very short population with this insurance. And there are a lot of people paying private, but they cannot afford the hemodialysis treatment or maybe peritoneal dialysis treatment. So a lot of people dies without any treatment. So I think this is problematic in all Latin America. I have read some papers from SLAN. So I think we have the same problems. For the renal replacement therapy treatment possibilities of kidney disease, we have from chronic kidney disease, peritoneal dialysis, intermittent hemodialysis with fistula and with catheter, with tunnel catheter, and also the kidney transplantation. And now we have this rising because of what I say before, the palliative care. So for acute kidney disease, that is our expertise area. We have continuous renal replacement therapy, PERT, intermittent and peritoneal dialysis. Home hemodialysis programs are non-existent in the country, so we don't have any possibility to have this because it's not in our laws, and there is no company offering this in the country. Also, we have around 140,000 patients with chronic kidney disease, but only 50% go to the government areas, most of like what I said. And these patients are always in the last, most of times in the last stage. So it's kind of difficult to convince them to start treatments because it's the first time they know that they have chronic kidney disease, and most of the time they don't understand what is happening and because why nobody told them about this disease. But I think we have all the same problems. About the cost, peritoneal dialysis is around $6,000 per year, and hemodialysis is around $9,000 per year. And we understand that hemodialysis is expensive, but now we have a lot of patients wants to have hemodialysis before transplant, and but we have been rising peritoneal dialysis after COVID. I think everybody do it because it was safer for the patient. So we have these two emergence ideas. So it's expensive, and the other part of the treatment, that it's the medication and drugs, also patients have to pay between $250 or $500 per month. So it's also expensive for the patients to keep the treatment complete, not only the kidney therapy, also the drugs. So this is our unit, hemodialysis unit in Hospital Universitario, and we have 60 machines of hemodialysis. We work with this formula, and there is another kind of hemodialysis in the country with the other technologies. This is not the only one. And about the peritoneal types of we have the ambulatory, and we have the continuous with the cycling peritoneal dialysis. Most of the patients that have the cycling are at the institution. If the patient have to pay for the machine in private, it's almost the same as hemodialysis. So it's not less expensive if it's in private, but the institution can choose patients, most of them to have this at night, to have this at the time they are sleeping, because of they are working and they are producing a population. So maybe one of the most used criteria to give a patient cycling. So because I see this one and I really thought it's very interesting, you have been getting better, and your experience has been a very good example for us to improve our use of peritoneal dialysis. Most of time, and I have seen in patients, as it's said here, in acute necessity. So we also have these papers about how that can dysfunction the catheter or the dialysis if we use it very early. But in Mexico, this is the most common thing that happens, that we have to use the catheter of peritoneal dialysis in the first 72 hours. And it's not that bad. I think most of the time we do it good, as we say here, and the dysfunction is not that bad. So I don't know, maybe at the end you can tell me how you do it and how is it. And also in Mexico, we have two different kind of people that put the catheter, the surgeon and the nephrologist. And we have a better results with the nephrologist intervention, but I don't know, I think maybe it's the expertise of the surgeon that maybe makes works better. We know that the most of the problems of the patient to have access to the care of chronic kidney disease are the socioeconomic status and the lack of universal health care. Because of that, I said maybe we have all the same problem in Latin America. The education, not only from patient, also for the medical team, because some of the times who have to make this care of the patient is not the nephrologist, maybe it's the internal medicine or familiar physician, because there is no nephrology there. So we have this also the discrimination problem. I think always there is a problem in Latin America. About 2 words about transplant, we have in Mexico, most transplants are about the live donor. We have 30% of the dead donor, and most of the transplants are in public institutions. So we have most of them in the Instituto Mexicano del Seguro Social, and we have a long list of waiting, like around the 15,000 patients. So most of the patients that have the transplant before 2018, it was of live donations, and now I think we are doing the same. About acute kidney injury, that I feel really more comfortable than before, I will like to share that we have been trying to participate and collaborate with the papers and works in Latin America, trying to show that maybe this is in Mexico not that real true. Maybe you are more like near than us, and I think we are more like you. So maybe because we have done enough information to share. So now we are trying to do that. But in the thing that we are completely agree is that the critical ill patient is the one who can be most diagnosis with AKI. So this is our most study area. And also we have these problems in patients with AKI, also with the necessity to have nephrologists in some areas, and maybe some hospitals that have ICU don't have nephrologists. So we have been working a lot with the intensive care, and I think we can do a great teamwork for get better with the patient with AKI. So in Mexico, like in all the world, maybe sepsis is the first cause of AKI, and most of the patients at the ICU. It's more common in men than in women, and the patient that needs with AKI kidney replacement therapy is around 30%. The mortality goes around 22%. I think if only we have this AKI, but if we have more than AKI and sepsis, I think the mortality grows. So we have the different kind of therapies. We have in ICU intermittent, and we can do PERT, and we have also continuous renal replacement therapy. So maybe this is most of the used ones. We have also the possibility to do peritoneal dialysis in AKI, but it's not what happens most often. And we have the decision of how to choose the modality of the therapy about the medical condition, the resources, and the expertise. We have been doing some encuesta for patients, for trainings, and we are asking how often they use the continuous renal replacement therapy, and we are glad to say that now is growing. This is from the last year course, and now we have around the 50% of the hospitals that have a nephrologist are giving continuous renal replacement therapy. And we know that we have to increase this population, but now it's better than before, believe me. So we have to increase the nephrologists, and we have to increase the communication and the partnership between nephrologists and intensivists to give patients a better treatment. We have we use exactly the same as you, and we have been working with different groups trying to see the advantage and disadvantage. And here in Mexico, I think the most common indication for continuous renal replacement therapy is the patients hemodynamically unstable. I think this is the biggest indication, and also patients with fluid overload that you need to go down not as fast as you can do it with intermittent hemodialysis. Also, we have the same indication than everywhere about the capacity of the kidney. And when we have this indication, the universal indications about the hyperkalemia, fluid overload, acidosis, or uremic syndrome, we start renal replacement therapy. In our hospital, this is around the pandemic, around the first 6 months, we start to work together in a work team, not only
Eu acho que ela teve um problema com a conexão. Bom, deixa eu...
I have seen.
Hi, Lilia. I think you lost your connection.
Where did you look? Yes, no, but I know I'm trying to.
Okay, no worries. I'll take your time.
I will change. Yeah, I will change the connection to my phone.
Okay.
It will be no problem. Now.
Okay, no worries.
Tell me
You're back.
where we were.
So there was that chess game between death and the physician.
This?
Yes, this one.
Thank you. Okay, so we were trying to get better the patients and offer as much as we can and try to avoid IKI as much as we can. Try to avoid the necessity of kidney renal replacement therapy. So we work together with this team, also with not only intensivists, also internal medicine and infectology. And in that table, maybe you can see a lot of people around. They were trainings and fellows in another specialties like gastroenterology, hematology, and everybody was saying what we, for each patient, everybody say what we have to do with the specialty that we had. And it was very nice teamwork. And it works also how to get better and faster the patients, because we were all there inside. And also when we, as a nephrologist, start seeing these patients, we start to do some urinalysis. And we have this work at the ASM. This in the last World Congress of Nephrology. With this urinalysis, we can see if the patient at the first urinalysis has proteinuria and hematuria, the possibility of have a Cadigo 3 stage, it was higher, and the possibility of death, it was higher also. So the first urinalysis could be very interesting in patients with COVID, and also if the patient go to ICU, also the increase of mortality, obviously. So we also work a lot with other people from Mexico and Latin America, trying to help other cities or other hospitals to choose how to transition between therapies and to offer therapies as much as you can. So we have to also to have these problems to go inside of the area with all your PPE and have to put catheters with patients in prono, and we have to improve all our skills. So it was kind of interesting time. So like, we have in Mexico different kind of technologies. We have PrismaFlex, Prismax, Amplia. We have Multifiltrate, and we have the APAC. I know that it's coming this from B Brown and Omnia, and it's coming also the new from Multifiltrate, or the new from Fresenius. But we have this most in the country. We have also to work with the transition, or as I saying, we can have 2 or 3 continuous renal replacement therapy equipments. And then if we have another patient, and if our patient is getting better and without vasopressors, we can migrate the therapy to other patients, as we propose in this paper. And I think COVID make us more efficiency and more care about how to prescribe therapies and how to move the patient around the therapies to offer a better prognostic. So also we have this opportunity to make more PERT, and we have here in Mexico the most use is SLED, I think, and we are very I think expert in this. We have more of the patients that after 3 or 4 days gets better with the continuous renal supplement therapy go to PERT, and then after 2 or 3 sessions it gets better, maybe have intermittent hemodialysis. So we are doing this around all the hospitals. It's difficult to use peritoneal dialysis in AKI, but it's possible, and most works have been doing together with the intensivists. Here is an example. They contact us as a nephrologist to work with them to how to offer the peritoneal dialysis in AKI for the patients with COVID in the first wave, and we do this together. So how to do it with cycling, and how to do it manual, and how the solutions, how to work, and how we classify the patients with a high volume overload and not that much overload, and then we decide the kind of back, you know? But it was very interesting to do this with them, that they are not so much familiarized with this idea of the PD, but they do great, so it was very nice. And then you became to publish these papers. I think Daniela have been a great work with them, and this fluorogram was very nice, and we start to use when we have the patient. I think I have done like 3% against the 90% continuous renal supplement therapy. But we have this idea of the migration, and we try to keep as much as possible. We use the same criteria than I think everybody about to stop a therapy. But I think one of the most difficult times of this around the COVID, it was the time to say it's not going anywhere, this patient, so we had to stop. This picture is not from that moment. This picture is from a patient that was waiting heart transplant that goes in cardiogenic shock. And as you can see, have a lot of machines around. And I think this is one of the moments that you have to say, if you are going to somewhere or you are not going anywhere, this patient then collapse the lung with a massive thrombosis, and then we stop everything. So because we were not going to anywhere. So this is very kind of a difficult thing sometimes, but we have to learn that we are not God. So it's kind of interesting now after COVID. Around most and echoes, we do a lot of things here in the city. Maybe there is not all the country that can do as much as we do. I will show you, because we have also a very interesting programs about the transplants. So we do a lot of most. We have also the possibility to offer here ECMO, the hepatic support, the plasma exchange, the continuous renal replacement, and all the heart support that you can offer. And also we have here all the hepatic support that we can do. As we were talking at the beginning with Thiago, we have all the possibilities. And here is the other hospital I work, is Christus Muguerza. Here we have a ECMO unit, and now it's bigger than this one. Here were like 8 beds, and now we have 15 beds. We have a huge department, and we can offer as much as you can see here. And we have the ECMO, the CRT, the MARS, the absorbents. And this patient, as you can see, have a acute hepatic failure. And this patient was from the COVID moment. He had a COVID pneumonia. So we do a lot of echoes. Also, we have a lot of possibilities to use the sorbents, and we have here in Mexico Osiris, we have Cytosorb. Now it's just arriving the Jafron, and all the variations of the Jafro sorbents. And we have also CPVA, as you see, amplia there. So we are trying to improve our situation with the work in the multidisciplinary approach. We know that we need to have a very quality expertise in the people, in the difficulty of the patients. We try to keep a balance between the preparation of the nurses, the nephrologists, and the critical care physician, and try to keep working and understanding between us with all these pathologies. We also can offer different kind of therapies, as you see in the picture, in the same time. As we do some special situation as lung transplantation program, we are the only lung transplantation program active in the country. And we have this also possibility to have patients from others part of the country to come to us. But sometimes not everything is so soft, and sometimes we have some turbulence, and we have to offer, as much as you see, plasmapheresis at the same time as CRT. Even if we can do with the CRT machine, there are some times that we can't avoid to try to have the gold standard. No? But we do it all that. That patient that you see here, it was 4 months in the hospital after the lung transplantation. We had 3 months the kidney failure, but he has only 1 month the continuous renal treatment therapy. Then we do some PERT, then hemodialysis, then nothing, and then the patient comes out and go to home. So now he's 0.9 creatinine. This is another patient that also received a lung transplant, and then have this another one. And as you can see, this also the machine. So the lung transplantation program has the need of the renal supplement therapy sometimes. Also the hepatic transplantation needs help sometimes. We are here from the bridge, and then we are here in the between of the surgeon and in the surgical, and then we have all the patients go there, and was very fine. And all we can have this all the pictures from the COVID time. Now you are seeing the auxiliaries, and then we are having the site servants, and then you have the possibility that see this case report, and then the patient survive after all we do. And even if the body masks index, the patients survive. Sorry for the WhatsApp sound in there. So almost for finish, we have this is one of the most famous patients, and this is have a transplant. This transplant was done in the last year, and this patient, it was at the beginning with the AKI, then stay for rehabilitation and to prepare to get the lung transplant of the after the fibrosis, and then the patients go to the transplant. Then 3 days before the transplant, we suspend the kidney replacement therapy, and then we have this patient. And it was the part of the team the day he was here in this picture, and then he went out walking by his foot. So it was very amazing to see these patients, and I really would like to share this experience with everybody, because he was almost dead when we arrived with us. And I think for the end, we have to say the future is landing here in Mexico about the biomarkers, about the POCUS and VEXUS, and about the real-time creatinine that we are waiting very excited. So maybe if you have any question that I hope I can answer. Thank you.
Excellent, Lilia. Amazing talk. You know that it impresses me because in the places where I work, we don't have this structure for doing this much transplants, except for kidney transplant. and we know the complexity of those surgeries. When I was in training in my fellowship in nephrology, I was in a hospital for 2 months, and there they performed lung transplant, heart transplant. And so it's amazing that you have this opportunity to work with all these complexities around. And my first question is, why Monterrey has all these developments and not Mexico City or Guadalajara? So it's because of you? You're on mute, you're on mute.
Sorry, no, definitely it's not only me. I think we are a very lucky city with a lot of very prepared people. All people that you see in that picture went for a special training, and maybe we have the lucky to be together in the same city and make these things happen. But I think one of the most important thing is that Monterrey is the biggest city with the most money in the country. It's one of the cities with more money, and we have the industry here. Most of the industry of the country are here, and also most of the people with insurance is here in this city, and so maybe that's the possibility to do a lot of things.
And your colleagues, they go, it's common for them to go abroad because you're just across the USA. So is it common for people to go there and do fellowships and internships? How is that?
It's easy for here from all the Mexican to go there, not only because we are near from the United States. There is a lot of people in Mexico City going to United States, or it doesn't matter. But I think that there is some difference here in Monterrey because we have a lot of patients from the United States come here to Mexico to have the treatments.
Because it's cheaper.
That's the other way around. Yes, because it's cheaper and because we have a easier way to do the things. Maybe the institutional medicine there, it's harder from there.
Oh, impressive. So Lilia, I'm waiting for questions, but I think Professor Francisco has opened his mic. So Professor Francisco is currently my mentor in my PhD, and he's a nephrologist, but also a scientist because he works with pharmacology, molecular pharmacology, and he has also worked as a postdoctorate in San Francisco. So
nice to
Hi,
meet you.
Lilia. Nice to meet you too. It's a wonderful talk. I really appreciate it. And I'm his mentor, but he understands more about dialysis, intensive care unit, much more than myself. I'm learning with him a lot. And Lilia, my internet signal was not completely clear, and maybe I missed some parts. First, I met a lot of my former mentor in US. The last 10 years, he works in Houston in Methodist Hospital. And I met a lot of different students from Monterrey University. And I know that Monterrey University are making a lot of efforts to train even undergrad students in US, right? These people were undergrad students. And it's wonderful what you guys are doing in Monterrey, and as I understood, most of the hospital is just a private hospital as the university, and the health insurance company are paying for the costs of all the facility, etc. Is it right?
Yes.
And I know if I lost, but 50%, around 40 to 50% of chronic kidney disease that needs any kind of hemodialysis or peritoneal dialysis they are completely out of the system.
Yes.
Wow, it's a lot of people.
I know, because of that, I show you that map with the ideas of how to get better this situation. I think it was from Magdalena Madero, that she is in Mexico City, that they are trying to make efforts to improve these opportunities. Also, Dr. Guillermo Garcia also have been doing a lot of work around to try to the government to understand that how many people is taking no medication or have no treatment because they can afford it, or they don't have the opportunity to get to the nephrologist or the hospital with the opportunity of the treatment.
And the Universidade Autônoma de Mexico City is a public university, right?
Yes.
As I understood, they have also hospitals that take care of public patients, right?
Yes.
And what about the acute kidney failure injury, AKI? In Mexico City, they can provide access for people, at least in the hospital of the Universidade Autónoma de Mexico.
They can offer if the patient can get there, but most of the patients are in long cities from the hospital, or in cities that they don't have a hospital that can offer the treatment. So most of the times patients can't get any nephrologist.
Okay. And another curiosity, I understood that peritoneal dialysis, it's a nice option for AKI in some situations, right? And do you have a comparison of what was the outcome from patients from peritoneal dialysis? And I believe that it's more cheaper even for the private providers.
Yes.
And do you have in comparison the outcomes of peritoneal dialysis and extended dialysis, or even intermittent dialysis?
I think it's with the training. The difference is with the training. We have more in the ICU, we have more nurses and nephrologists and intensive training in kidney replacement therapy with CRT or HDI than with the PD. So I think it's more about the training, but there is a lot of hospitals in the south, maybe, or in the coast, that they don't have any kind of the machines, and they start PD and they do it really great.
Well, congratulations. As I think you are on the topics of the nephrologists in Mexico. And I never been in Monterrey, but I heard a lot of good things about the city and the university.
Hopefully, maybe you can come sometimes and bring Thiago.
Oh, I hope so. Maybe.
No, I will try to bring Thiago someday. I really try to do it.
Maybe I just can be just a fellow with him, but I'm sure he can provide his data. It's going to be a good thing. Thank you.
Thank you.
Thank you, Professor. Lilia, I will move to more hands-on questions. Yes. Because here in Brazil, as in Mexico, we need to improvise in some situations. We are more creative than, let's say, the Americans, that they don't think outside the box in many situations. So quick questions. So when you're prescribing PEERT, or SLAD, which is the blood flow that you use?
200, 250 as much.
Okay, 200. Dialysate flow?
Maybe 300 as much, 400 up.
And for example, for the whole treatment, you use dialysate, or like you do 2 or 3 hours ultrafiltration and dialysis, and then the rest only ultrafiltration? Do you work like that?
Yes, we do a lot of this. Yes. Yes, so most of with the therapies that is during more than 6 hours, we do that.
Then after 6 hours, only ultrafiltration, correct?
Yes.
Okay. The temperature?
We 35.
35.
35, yeah.
So the average duration of treatments like 6 hours, 8 hours, 10 hours?
6 hours most of the time.
6 hours. Okay. Do you know the concentration of potassium in your bath, in your dialysis?
We have potassium 2, but we do 3. So we add the
Okay.
ampollas, yes, to
Yeah,
make
it's
to
like,
be
you know,
in safer line, yeah.
yeah, you know, that's interesting from different parts of Brazil, because when I was training in São Paulo, we used to add these vials of potassium. Like I remember it was like 9 vials to increase the concentration in 1 point or something like that. But here in Brasilia, this is kind of not well seen, because you are spending too much potassium, you know, instead of replacing in IV. So here in Brasilia, places where I work, we are not kind of allowed to add on the dialysate and on the exit dialysis, so we need to replace intravenously. But that's a smart, it's a smart thing to add on the dialysate, the exit solution. About the calcium, which is the concentration of calcium?
It can vary. I think I don't remember very well, because we have this prepared before. I don't know.
Okay.
But I think I don't know if how is yours, but I think it's the standard way. I don't know what is your one.
So here we have 1.25 mMols per liter, 1.5 and 1.75.
Yes, most like as 3.5 something. Like
yeah, 3.5 in
yes.
milli equivalents.
Yes.
And usually for AKI patients, we use this 1.75 or 3.5, because sometimes they develop hypocalcemia. So that's kind of the standard. And about glucose, do you use glucose in the dialysate, or is glucose free?
Glucose free.
Okay, interesting. For us, sometimes we use dialysate with glucose. I like it more because sometimes AKI patients severely ill, they develop hypoglycemia. So we are used to using glucose in our dialysis. So now moving to CRT. So this is kind of like those TV shows, you know. Tell me the color you like, your favorite dish. So the catheter, which catheter do you use for CRT? The lens and the French?
We try to use, because not every time we get what we want, but maybe 13 French was the better for us. But
Okay.
sometimes we have only 11, so we have to stay with 11. Yeah, and also with the length, we prefer 19, but sometimes it's 15 or 16, and we have in an urgent, so we have to put what we have.
Yes. Blood flow?
We between 150 and 200 because of the weight. If the patient is around 70 kilos, we more of the time we do 150, but the patient is more than 90 kilograms, it's 200 or 250 between.
Okay. And as anticoagulation, you usually use heparin, right?
Yes, we usually use heparin. We do sometimes citrate, but it's not that common. But in Mexico City, in cardiología and nutrition, and the Instituto Nacional de Nutrición, they use more citrate.
Great. And the dose, the dialysis dose?
More between 25 and 30. And if with the patient is hypercatabolic or sepsis in the first 24 hours, maybe sometimes I give 35.
And in Brazil, often we go further than 72 hours with the same filters because they are expensive. So in your situation, you are forced to change the filters if they reach 72 hours, or you can go further.
It's different in the two hospitals. It's different in the university hospital that it's from government. We have like 2 filters, and you know, as much as you can make it the longer life can do. But in the private, we can go as much as we like, but we are trying to keep the patient, the money of the patient, the most of the with a quiet situation. But I really prefer to keep the patient in CRT and then go nothing. It's saying that after CRT, you have to give nothing in the hemodialysis, but sometimes we are forced to make the migration. So, but most of the time, the old patients that you see with the lung transplant, they were only in renal replacement therapy, continuous replacement.
And
they never have hemodialysis.
Just because you've mentioned lung transplant, here in Brazil, we have a huge solid organ transplant. So we do 5,000 kidney transplants per year. And here our government provides the medications, which are expensive, you know, tacrolimus, mycophenolate. In Mexico, for transplant patients, is it the government that pays for the drugs, or patients need to pay from the out of pocket?
The patients that have the institution, the insurance, the government gives them.
Oh, okay. And so Fabricio, which is a nephrointensivist here in Brasilia, he asked the question here in the chat, so I will read it loud here. So he said, I'm on shift today, so I might have missed it. So he's working, but trying to follow your... oh, how is it in Mexico? Like in Brazil, the shifts, they start at 7 a.m. and they finish at 7 p.m. Is like that in Mexico?
Yes, kind of, yeah. But we have different, I have to say that I don't make any call from 5 years ago, but you have your phone with calls and message all the day. So it's like a permanent call, but yes. But in the public health, they have this calls like 8 hours or 12 hours.
Yeah, so it's the same here. So he have a question about chronic kidney disease, even though you are an AKI expert. How is the proportion of PD over HD treatment for chronic patients, like the percentage? Because we hear good things about Mexico, because all the big trials involving PD, and after the earthquake that has moved a lot of patients from HD to PD. How is that proportion?
Now I think institutional patients are more on PD at the start, and it's a very nice program. It has been a very growth program at the beginning, as I show you in your infography that from Brasilia. I think here in Mexico is working something like that, when the programs, when the training nurses, and with the possibility of the patient to get somebody that maybe is not the nephrologist, but maybe the nurse, to improve the program. Now we have a lot of patients in PD with chronic, and also in our hospital, in the university hospital, we have been increasing like 300% patients in PD than before, but we do a lot of hemodialysis also. I think if we have to talk about the complete picture, maybe in the country with chronic kidney disease, it's like 60% in PD and 40% in HDI.
Yeah, here is around 90% HD and 10% PD, but we need to grow on PD because some regions, like the patient needs to travel 300 kilometers to go to the dialysis units and then return. So this patient would work better, of course, in peritoneal dialysis.
Because of that, we have that a lot, because in the small cities, like rural centers, the only possibility is PD.
Yeah.
There's no other way.
And one curiosity, when I was in Italy, I was surprised because in the ICU, they use a lot of dopamine. So here in Brazil, we use as first drug noradrenaline, norepinephrine. And when it goes higher than 0.3, we also associate with vasopressin. How do you manage vasopressin?
Exactly as you said. Exactly as you say, norepinephrine first, then vasopressin.
Oh, that was
We here have been revving the dopamine only because if you have to rise the pulse, this is the only way to.
Yeah, okay, so it's the same. And here in Brazil, many hospitals, even here in the capital, they don't have an ultrasound available for catheter placement. Is this the reality in many hospitals in Mexico still? So for line placement, you do it without the ultrasound?
No, now the reality is that there is a lot of places where they do this, but now by law, you have to do it with the ultrasound. We have this norma that say that we have to do it with the ultrasound. So if some patient who is getting a catheter without the ultrasound make
an accident,
an accident, and then this go with to a complaint in the judge, you have all the possibilities to lose your cedula.
Certificate. Yeah. Okay. Yeah. I think that's important. I'm always stressing this point here because you can avoid many situations that were completely avoidable using the ultrasound, but there is a kind of resistance here. Sometimes even in the ICU there is an ultrasound available, but physicians, they say, oh no, I can do it in the old way. So, but this, I think it's unacceptable these days.
Yeah, by this day, yes.
Yeah. So Fabricio is raising his hand. Move forward, Fabricio.
Lilia, felicitaciones. A mí me encantaría hablar español, pero no voy a hacerlo con vosotros. I think it was a great talk. Thank you. I really appreciate it and learning a lot. I think it's focus and ultrasound for catheter placement. I think what Mexico did is important. It's a norm to use the ultrasound, because if not a norm, so it's maybe 80% of time it's quicker to place the catheter without ultrasound, because it's easier. You don't have to use a machine and to protect it to make it sterile. So I think the point has to be a norm, and then the health system has to pay for it also, because I have talked to some ICU chiefs, and it is a problem because they don't pay for it. So it's increased the cost for the service, but the service can't get from it, except for the low incidence of accidents. Of course, it's important also. But I think the norm is the point for the ultrasound really gets into the ICU and the nephrology and the, like trauma surgery. Yes. I think that's the point, the norm.
Exactly. I think it's for the sake of the patient. At the end, this is protecting the patient and also us, because if you go with the ultrasound, you can find things that maybe you don't know that it were, like the anatomy changes or the thrombo, or if the patient had another catheter before, maybe stenosis or something like that, and you can avoid these kind of problems. For us, it's now very quickly to do it. We have this, when I was a fellow in the nephrology at this hospital, we just change clocks and we jump patient from patient to do it, and maybe like 5-8 minutes between one catheter to another with the echo. It's really fast when you have the training. And I think now all of us, we are learning about the POCUS and DEXUS. And I think now the ultrasound will be also another tool. So we don't have to think only in the ultrasound about the catheters. We can use it for another things. And now maybe it could be inclusive lower the cost because you don't have to go to the TAC. You don't have to put out the patients from the ICU to go to a image study. And you can also maybe do the things that in another times do another one, that maybe, oh, I found this pleural effusion, I can put it the width there and then do everything. I think this is a new era where we are doing a lot of intervention as a nephrologist. And I think maybe we can make this synergia with the intensivists and find the use of the technology to make better and faster diagnosis and treatments. And that's the way I think we are going to.
Yeah, I think the echo is going to be a part of the physical examination.
Yeah.
You know, like hemodynamics and thorax and abdomen. And it's a really good tool. I think that's the way. I'm really enthusiastic about the ultrasound, although I have to learn a lot of it, but I think it's a good way.
We have also to learn always. I have to say that now I'm taking this focus course. So every day change the information. So we have to learn every day. So,
yeah.
No worries.
Congratulations. Thank you very much.
And Lilia, one last question. In Mexican reality, who places the catheter? Is the nephrologist, the intensivist, or the surgeon? How is it there?
In our hospital, in the public health, is a nephrologist. But if you go to private, maybe some that we use a lot, and maybe you don't say it, is the interventional radiologist.
Yeah, we do have it here.
Mm-hmm.
Yeah, they do everything possible, right?
Yes,
all the
exactly.
procedures.
Exactly.
Yeah.
So maybe here, these are the two ways. More than surgical room is the imaging room.
Okay, so Lilia, thank you so much for this excellent presentation. I think everyone enjoyed and learned a lot. This presentation will be recorded and we will upload it to our YouTube channel. So I will share with you and you are welcome. So in the future, I hope that we will have some dialysis courses here or intensive care courses in our city, Brasilia, which I love so much. I was born and raised here. So thank you so much. You were so kind for giving us your time and your knowledge. So
thank you for the invitation, and it's a pleasure to be with you.
Okay, hasta
I hope to
luego.
see you
Okay.
soon. Nos vemos. Buenas noches. Bye.